Good afternoon, everyone. My name is Garrett Schmidt, and I am the managing editor for ACOexhibithall.com. And I would like to welcome you all to today's webinar that's live and is hosted by HealthEC. And it is titled 10 Tactics ACOs Should Avoid and 10 Strategies for High Performance. A few items of note before we get started is all attendees have joined today in listen-only mode, so you won't need to worry about muting your microphone. That has been done for you. And then also during the webinar, we want to hear from you. So please submit your questions. We will have a Q&A time towards the end, but you don't have to wait until then in order to submit your questions. Go ahead and do that at any time throughout the presentation. And we're going to get to as many of those as we possibly can during that allotted time. If we don't get to yours for whatever reason, we do have a lot of attendees today, so we will do our best to get to those, but if we don't, we will follow up and answer them via email afterwards. And then finally, today's webinar is being recorded, and so you'll have the opportunity to rewatch it after the fact and share it with colleagues. And I'm going to, afterwards, what I'm going to do is send out a link to everyone, and it's going to have a link to where you can get to the recording as well as a download for the slides themselves. Now, we, in full disclosure, we're having a little technical issues with ACO Exhibit Hall right now, so something with our hosting company, so that should be up very soon. So the link I'm going to send you is actually going to be a direct link, but that will be up very soon, and I will send you out also a notification letting you know that that has all been fixed, so you shouldn't have any issues. So without any further ado, I would like to introduce our speakers today. Dr. Ann Polich, who's the CMO of Sync Health, and also Dr. Sanjay Seth, who's the CMIO of HealthEC. And Dr. Seth is going to get us kicked off. So welcome, Dr. Seth.
Thank you, Garrett. And I have asked Dr. Polich to join me in this session as the Chief Medical Officer for Sync Health, which serves, I think, 2 states now, Nebraska and Iowa. And we have entered into a collaborative arrangement with Sync Health to offer population health service platform and technology to Sync Health's clients in both those states. So thanks for joining us, Dr. Polich.
Thank you.
We thought that we would start off by talking about a little bit about what are the tactics to avoid. Typically we see that there's so much data made available to the ACOs now that one can get totally complicated in the strategy that they pick to achieve success. So the first point is, do not overcomplicate the strategy. Setting the strategy with too many objectives and goals and changing them every quarter sometimes does not make sense and causes more confusion to the provider community as well as the staff. So simplify the strategy. Maybe pick 1 or 2 elements of the ultimate triple aim objectives to focus on for the whole year, and then for each quarter you can select a different aspect of those 2 strategies or strategic goals, and then make sure you do not have conflicting strategies. You know, sometimes things that improve quality would also improve cost. So make sure that you don't send conflicting messages to your staff and the physicians about doing something that is actually counterproductive to different objectives that you have set for yourselves. The one thing that's most important is, do not lead any strategic or initiatives or goals based on anecdotal evidence. And as physicians, we often resort to, no, in my experience, this is what I've seen. We need to help the physicians avoid those kind of statements and setting themselves up to achieve something that is totally anecdotal. Until that's supported by data and evidence, try not to select those kind of strategies or goals, because different providers with different specialties in different areas may think differently, and that will cause more confusion. Do not limit the perspectives of the frontline staff. You must engage the frontline staff, which is the nurses, the registration folks. Remember, they are the face of the practice. They are the face of the ACO for the patients. So make sure you include their input in how the strategic goals are selected, as well as how they are articulated back to the rest of the provider community. While you're doing that with your staff and the frontline staff, they will tell you, and you should ask them, for what resources and other data requirements do they need to help pull this strategy off in terms of operations. They are the boots on the ground. They have to do all the work. We can only guide them. So make sure that you identify both technical data and labor resources required to execute on those strategies. Those were the first 5 things that I would say to avoid. And Dr. Polich, would you talk about the next set of tactics to avoid?
Sure. Thank you, Dr. Seth. First of all, number 6, encouraging health inequity so that you know that all patients are being treated the same. And so I'm sorry, not encouraging health inequity, so encouraging health equity. Do not set targets that are not under the provider's control. For instance, many physicians have been asked to have a metric of hemoglobin A1C that they know that they're not going to be able to budge because that the patient really has not been able to engage in the care. So better to look at really process measures or other metrics that are more in their control. It sets for a very good dialogue and partnership with providers. Clinical decisions that are based on limited data don't allow treatment of the whole patient for value-based care. So really, we need connected data. We need to be able to make a change that will really go across the value spectrum. And then don't launch strategies without the leadership, the clinical leadership knowing what you're doing, because then ownership is not taken. And as well, you will spend much time trying to fix that kind of distrust moving forward. So really, before you launch into your strategy, getting feedback, as Dr. Seth talked about, but also being very transparent in what you hope to accomplish. Ignoring or not taking into consideration the socioeconomic status will really impact the patient's ability to achieve improvement in their quality of life and in their care. And so really we need to bring in socioeconomic factors, as we know that they are overwhelmingly responsible for whether the patient can be successful or not. Next slide, please.
And now we switch to what are the things we should be doing or have in our toolkit to ensure a higher performance. And what I thought was, with the background of one of our clients, who is a clinically integrated network of 240 independent providers and contracted physicians and specialists that have been managing about 40,000 patients under their different value-based agreements. And they have the MSSP program, they have a commercial program with the Blues, they have a Medicaid program also with the Blues, and have been managing these 40 patients through their provider network to achieve a better outcome, both for the patient and for the ACO as a whole. Started off by looking at ED utilization, going to their competitive hospital, and then utilization of cost and quality on managing chronic illnesses. This is what their challenges were. They were providing regular feedback to the providers was a challenge because they use multiple EMRs and the population health platform data was available elsewhere. We managed to connect all the EMRs to our population health tool and created a bi-directional feed so that the providers can get alerted either on the individual transaction for admissions, discharges, and transfer that somebody like Sync Health gets from all the hospitals and nursing homes as an HIE. We fed that back to the physicians in real-time basis, and that giving them the data at their fingertips while they're within the EMR made it a much easier communication tool for us. The social determinants of health was a special focus for this group, and they managed to, what they were originally thinking was do interventions that cannot be billed for, and they thought that that was a waste of money, but now that they've achieved success and they contribute a fair amount of that to the addressing of social issues, this group has now improved their score on the MSSP to 100%, because the gaps in care using EMR data was also used to close the quality metrics, as well as in 2020 they had over $5 million in shared savings with the MSSP program. For the Medicaid population, we managed that through an MLR calculation that was negotiated, and they dropped it from 93 to 87%, which gave them an overall, between the commercial, Medicaid, and MSSP, they ended up with over $8 million in shared savings. So clearly using data and the ground troops and provider engagement appropriately did make a huge difference. And that is the first value add that you should look for, or a toolkit that you should have, an element of you should have in your toolkit, is to be able to analyze the data to identify trends and outliers. And so that, remember, it begins with the individual patient. So if you don't identify the outliers, which may be one or more patients, you still need to start addressing them first before the general population. So you must have a good analytics tool that now analyzes both claims and clinical data to create a visualization of trends and outliers. Again, using that in this particular instance is to establish specific goals. And we can talk in more detail about this, but if it is to reduce admissions, where if your hospital cost of inpatient care is above the average, then to reduce admissions, physicians don't understand necessarily, or the practices want targets. So set the target by practice, by provider, to say, hey, if you can reduce your admissions by 10%, which may be only one admission or two admissions per practice or provider, it's a very achievable target. And if you have identified the outliers, they can bring in those outlying patients into more frequent encounters with the practice and the provider, and that will achieve their goal. So establish very specific goals at the most granular level possible. And here we would talk about it, practices and providers. The progress or the performance measures should also be analyzed at the practice and provider level. Although peer group comparisons are good enough, but still it has to be done at the individual provider and patient panel level, so that there are disease conditions for which patients have not been seen and have ended up in the emergency room or in the admitted to the hospital. As we are all aware, about 30% of all ER visits end up in the hospital. So preventing ER visits, which may not be a cost issue, but preventing the admissions from the ER will become a cost effective strategy for reducing cost. Again, creating a strategy, talking to the ground staff, ground level workforce, as well as the providers. Make sure that the operational strategy or the operational changes that need to be made to achieve the strategic goals is clearly understood, and how they can implement it within their own office setting. That's a very important strategy, and that you cannot do at the corporate level. You must have that input from the staff in the practices and the providers to say, okay, how would you attempt to operationalize them? Give them suggestive guidance, but not don't ignore that an operational strategy must be correlated with the strategic goals and objectives. Frequent communication between the provider, the practice, and the provider and the practice and the patient must be made. If you don't have these communication goals, if you do not have self-management plans agreed to by the patient, all strategic goals and then all operational goals will come to no end, because if the patient is not cooperating or engaged in their own care, it would not be an effective strategy. In addition to that, every step of the way should be in the form of data visualized, so that the practice and the providers can understand how far they are from achieving their strategic objectives and where they need to accommodate operational changes. That communication protocol must be established, and it should become formalized, so that it is expected that on one particular day of every other week, that the administrative team or the analytics team are going to be in touch with the provider and the practice to educate them on their progress and how far they are or how much they have achieved already. That reinforcement is also essential for continued success. Dr. Polich, this one I would like you to talk about.
Thank you. Setting your achievement milestones are very important, and especially thinking about them in a time-bound manner so that they connect with strategy and that you know where your milestones are and how you're achieving them. You really need internal metrics that your team agrees upon, and those need to be measured regularly, and then whatever deficits there may be in terms of the timeline, then putting resources to that to see if you can't get them to move forward. It is easy to lose track of the time, and so especially with providers who are very engaged in patient care. So really having someone oversee that and manage that will make it much more effective to meet your strategy goals. The identification of revenue opportunities engages providers and practices for them to know that not only will they be able to offer improved quality of care, but they can reasonably expect that they become more efficient at it and more effective and reducing the cost of care. And so some avenues to think about are through the annual wellness visits, as well as chronic care management and transitions of care. If transitions of care are very solid, then there are many opportunities to reduce emergency room visits to enhance communication and reduce readmissions. Data gaps. There are always gaps in the data that I think causes us to pause. And I think reevaluating where those are and trying to think through other forms of data that might be advantageous to complement what the current status is. But if there's not enough sources of data, then your analytics may be faulty and lead you to conclusions that are not helpful and certainly not going to be constructive in improving care. So those need to be fleshed out. Strategizing for optimal workflow. It's really one thing to have the software and programs be optimal for clinicians, because it's very difficult to know the workflow. And so I think that going back constantly to the front line, making sure that it's understood, making sure that the nuances or different departments are understood, so that conclusions can be made that are going to accommodate those workflows and be able to result in strategies that are effective. COVID has really changed the way we work and the way patients seek care. Really the consideration of new outreach methods without losing the integrity of providing care is something that every health system is looking for. And so video and audio preferences have really been the mainstay of delivering care during COVID. And then the abilities to aggregate data around social determinants and really bringing that into the data analytics to understand what the patient needs to be effective in improving their care and being a partner in the care as well.
The report is just one point here that we experienced recently is that everybody, in one particular practice, they all started talking about FaceTime with their patients, not realizing not everybody has an iPhone. And those patients had no idea what FaceTime meant. And so even simple things like that should be thought about in advance. Hearing, people who have a hard of hearing, they may not be able to do something over the phone. So all of that has to be thought about, even if you're doing telehealth and virtual visits. So some things, attention to detail is really, really important at that level.
Good point, Dr. Seth. And, generationally too, different patients of different age groups have preferences around how care is delivered. And certainly if there is visual and hearing impairments, one needs to really think through how perhaps they could effectively get someone into the office if transportation is the problem. So a lot to think through.
Yeah, well, my legal counsel he keeps telling me that you're promoting telehealth. Nobody worries about who else was in that room, either on both ends, and how much HIPAA attention to HIPAA has to be paid now that we are doing virtual entities. People walk in and out of offices and in and out of their rooms where the patient is, and you got to be careful about how and what is communicated while it's evident that somebody else is in the room as well. So lots of things to think about. I think we've tried to summarize what we think are the 10 points to be addressed, both for what to avoid and what to do for a good strategy. Happy to take some questions and see if we can add to what we've presented already. Garrett?
Okay, well, thank you guys. Yes, that was a great presentation, and I thought you both did a wonderful job of explaining. We did have a few questions that came in, so let me open these up, and in no particular order. And by the way, if you are out there and you have a question, please go ahead and submit that on your control module. You'll have a place where, not on the chat, but in the questions area where you can submit those questions. So we would love to hear from you. The first question here, and again, these are in no particular order, is can you share a strategy that has worked well to engage high-risk patients?
I'm going to fall back on the case study that we highlighted. We have seen through data that chronic care management for those patients with 2 or more chronic illnesses does have a huge impact on total cost of care through reduced ER and reduced inpatient care. So chronic care management for all patients with 2 or more chronic illnesses is a place to start. And what we added to that for this particular client, since they had over 20,000 patients with chronic illnesses, we added another element of risk, which is a frailty flag. And we picked eight or 10 conditions that could have been identified through some analytics in terms of dementia, fall, incontinence risk, and a risk for Alzheimer's or malnutrition, and added that frailty flag to the chronic conditions, and were able to narrow down patients to a manageable number for chronic care management. And for those patients that we could not do a virtual encounter, the advice to the providers was to increase the number of in-office visits or in-person visits for those patients that the algorithm had identified as high likelihood of hospitalization over the next 6 months. And those were two different strategies applied to the same organization. One which took the burden was taken over by the virtual team, and the other one that was burden was put on the in-office practice staff. So it has seemed to work. This particular organization ended up with 14% reduction in inpatient care, and so they jumped in terms of how much they were able to save and therefore get as a part of their shared savings.
I would just like to add to that. I think the continuity of care and being able to have whatever provider is connecting with the patient, be able to longitudinally, as much as possible, develop that relationship and trust. High-risk patients may have socioeconomic factors like we talked about that have yet to be identified, so really delving into those and trying to address those problems as well, instead of just recognizing them.
Garrett, you're muted.
Of course. What I'm always telling everyone to not make sure they do. Okay. Next question here is, how do I incorporate more data without interrupting or altering our physicians' workflows?
As the digital format of data is becoming more accessible, with EMRs being more compliant and the payers willing to share data, we do see EMR data coming in live and payer data coming in once a month, even with CMS every 15 days. It's once you set a strategy, you can incorporate the data, but don't alter the strategy based on the data coming in every day or every 15 days or every month. Wait for a couple of months for the strategy and the operationalization of the strategy to be put into place before you alter those elements with new data. So while the new data is very critical so that you're not chasing patients or issues that are no longer relevant, but that is a tweak rather than otherwise providers and practices workflows interrupting that on a monthly basis makes all of this unachievable. So just reduce the frequency of change while you're still incorporating the data to make sure that you're not missing a new trend or a new direction for a particular element. Dr. Polich?
Well, and then just to expand a little on that, really look at your visualization tools and make sure that they're helpful and that providers can really move quickly through them, and that it's in a way that get their feedback, that it's in a way that they can appreciate what the changes are. They really don't want to spend a lot of time culling through the data and then having it not be helpful.
Great. Okay. Next question here is, what is an ideal target that we can assign to our high ED utilizers to reduce cost?
In the beginning, I had stated that from the data what we are seeing is as high as 30 or 33, 1/3 of all patients that end up in the emergency room are admitted.
Hmm.
And so certainly looking at the ED visit data, especially if you can identify from the diagnosis and the data non-emergent visits or avoidable visits or visits for alcohol and substance abuse. If you can identify those patients, then those could be your preliminary target. And non-emergent or avoidable ER visits, it should be around 50%. You should target 50% reduction over the year of those visits. And between alcohol and substance abuse, somewhere between 15 and 20% reduction is achievable, is what we've seen. And just based on that, you're going to literally have your inpatient cost reduced. I think that's what we've seen from the data. Dr. Polich, I know you guys get far more information from the hospitals for emergency room visits. And do you see something different when you look at the population in Nebraska, for example?
No, I think you're accurate. But to your point, the more patients that show up to the ER, the more patients will be admitted. So I think the strategy is really about how to look at metrics that patients don't end up in the ER in the first place. You know, what's your access data telling you? Do they have nowhere else to go? Are the individual practices perhaps full and not able to offer? Do you have no urgent care in your vicinity? So, you know, really backing up to say, okay, it's problematic for non-emergent conditions to come into the ER, but what is really the etiology of why those patients show up there?
It's a great point. I think you reminded me of, we have a client in not so good a neighborhood in New Jersey called Trenton, and the ER visits were going through the roof because these patients, Medicaid patients, didn't have anywhere else to go. So the physicians in the ACO partnered with a couple of urgent care centers, and the urgent care centers became the after hours program for all these practices. So patients were informed that after 5 p.m. they could call this urgent care center. We gave access to the urgent care centers of the patient's EMR record. So if that patient actually showed up in the urgent care, they would have an entire history of the patient. And that diverted so many patients out of the emergency room that the hospital began to complain, saying, "Hey, how come your patients are not coming to the emergency room anymore?" But it was such a program that the patients loved it, because they now had a place to go without being in a chaotic condition in the emergency room, where they were being taken care of between 5 p.m. and 11 p.m. at night by an individual in the urgent care center. In fact, they expanded that program with Fresenius, and they put a dialysis chair in one of the urgent care centers. So all the patients who missed a dialysis during the week, instead of showing up in the emergency room, could come to this urgent care center, and there was a dialysis coordinator and a nephrology nurse assigned by Fresenius, who actually performed the dialysis on a sort of an ad hoc basis for those patients. All of that seemed to enhance the bond between the providers and the urgent care centers, so they weren't stealing patients from each other. And it gave the physicians a much needed lifestyle break of not having to worry 100% of the patients, 100% of the time of patients who needed care after 5 p.m. Big lifestyle change for the practice, the provider, and of course, convenience of the patients.
And even if you couldn't start, with things as really innovative as a dialysis chair, which is an outstanding solution, you could really ask your cardiologist to get together to have a diuretic protocol that could be instituted either in the clinic setting or perhaps in the ER, but that those patients could go home. So I think the sky's the limit, and that each system has differences in solutions and really the resources. So start small and be successful, and you can move to larger things like a dialysis chair.
Yeah, that's great. I love hearing those stories. That's really exciting to me. That's how it's supposed to be. So I'm very that's great. Good job. Okay, next question here is you spoke about health equity, and I'm wondering how can technology be used to narrow the gaps?
I think one of our biggest gaps in data is on the social issues or the social determinants of health and the data related to that. So I think technology can help complete those, get that data from patients as they come in through the office. And it doesn't have to be phrased as, oh, we're going to ask you some social determinants questions. It's like being real with the patient. Hey, how do you manage your transportation? Do you ever find yourself in a situation where you're not refilling your medication because of money or cost or access? And those are simple questions with easy answers that you can use technology for. And I know that I've been reading on the news that Uber has started a transportation program, I think on the West Coast, for physician office visits. And I've heard as one-way transportation, regardless of distance, to be $5. So you can patients who need transportation help, other than waiting for the Medicaid transportation system to pick them up at 4 a.m. for a 10 a.m. appointment, can utilize this. And now it's all digital. These appointments and these patients' information with the appropriate consents can be sent to somebody like Uber or a transportation company that can make it more convenient and timely for the patients to visit. That's one I think that technology can help. The other one that I've begun to see is there are mail order pharmacies that are putting Pyxis-like machines in the physician's offices and dispensing generic medications for free, and even for emergencies, and then automatically refilling the same prescriptions through mail order at a much reduced cost. So things like that technology can be used to do that. Now, we've seen examples of both, at least one I've read, one I've actually seen, and that I think that current state of technology can assist in both collecting that missing data for social determinants as well as solving some of the issues that arise from social issues. Dr. Polich?
Yeah, and I think, Dr. Seth, you articulated there are a lot of barriers to care out there. And I think if we are very good at unraveling those, we can get a lot more parity in healthcare for patients. And anytime that we are making an assumption of non-compliance, we need to really reevaluate that. We've all been to pharmacies that keep their PAR levels pretty low, and then you have to come back because your medication's not there. And not everybody can do that. And so to your point, can we have mail order? Can we have Pyxis in clinic offices? How do we make it easy to get the medication? How do we make it easy to get to the appointment? How do we identify when housing may be particularly troublesome? The quality of air, just on and on. I think that we have a much more robust way of collecting that social determinant information now, and that we can aggregate it and looking at it through data analytics to identify quickly who needs the help. I think what we need to try to stay away from are, endless questions for providers, so that it's very difficult to get a clinic visit, done. That we really have to use data to bring the data to them in a way that the visualization is easy to know where the problems lie.
I think that Sync Health has a great partnership with Unite Us, and I think adding an entity or an organization like that to the care coordination program at any practice will give you community-based resources for housing, for food, soup kitchens, Meals on Wheels, those kind of programs that somebody like Unite Us and NowPower, which is I think now a new member of Unite Us, they can bring a lot more to the table to assist with the community-based resources that could be made available to the same patients, and it's overall good care as well.
Yeah, Unitas, I think, is a really good social determinant platform where they can make the data available. And then I think health systems, ACOs, have a lot of partnerships with community-based organizations as well, that they can usually use that data in a very powerful way to communicate and to really understand who best can help patients and their families resolve issues.
I think for MSSP program, CMS had required every governing body of an ACO to have a community member as part of their governing body, and I think we should begin to utilize them, to their full. That is, you pick the right community member, not just anybody, and find a way to get the data that the community, or get the information on resources that the community makes available. We know church groups work. We know that they use church groups and meetings in churches all the time, whether it's for politics or influencing how voting occurs, or those issues. I think the same resources can be put to much greater use for health, and I think there'll be more willing participants within the community that would offer help when it comes to health rather than other issues.
Yeah, and I think what you're really speaking to is civic health and how communities, all health systems included, can improve health. And as much as we can bring the data analytics to support that and to improve both the quality and the outcomes, I think that's really important. At Sync Health, we're a health data utility, and so we really see that it's our responsibility to aggregate that data and to support the community as much as we can.
Awesome. Well, we have time for one last question, and here it is. And again, if you have any last minute questions that you want to ask, please do that, and we will make sure to get to you via email afterwards to answer your question. But the last question is this: what programs or interventions have been successful for diabetes disease management in ACO patients?
I think there's only, from my perspective, there's one thing that's always missing, and that is an achievable self-management plan for each patient. Without that, having a successful disease management program for diabetes is a waste of time. So unless you have the education for the patient and the tools for the patient to support their objectives, I don't see how the whole diabetes situation, if somebody wants to eat McDonald's day in and day out, doesn't matter what you do with their insulin or their metformin, they're not going to be able to control their blood sugar. So, Dr. Polich,
I think everything we talked about today, and specifically for diabetes, is one, identifying those high-risk individuals, two, having programs in place that support them, that expand out into the community, the social determinants. Does this patient live in a food desert? How do we get nutrition to them and really thinking around the central focus of the patient and the 360 degrees to make them successful. And really shift the paradigm that the health of the patient really is we only have very limited resources. We really need to expand our thinking and to put the fundamentals in place and then to develop programs.
Yeah, and I actually see this tying back to the technology question too from earlier, where I've seen more interventions with diabetic retinopathy screenings and that kind of thing that are able to catch early stage diabetes for preventative measures, and so it all kind of fits together in a cohesive plan.
Exactly, Garrett. And if those can be done in a primary care setting or in a setting where the patient's going to be present, that we don't have to, have yet another appointment in subspecialty care that the patient may not be able to make. I mean, if we can meet the patient where they are and get them the care when they need it, and use the data to really understand what their individual needs are, I think we'll move far down the road.
Agreed. Well, unfortunately, that is all the time we have for questions today. You guys are doing great work, and I salute you and continue to do what you're doing for the population, and it is very good. But unfortunately, again, that is all the time we have for today's webinar. So thank you both. You did a wonderful job. As we conclude, I wanted to encourage you all to visit the HealthEC exhibit booth at ACOexhibithall.com. And here you can see it on the screen here, you can learn a little bit more about their team and about what they're doing and their different programs, and get a little bit more of an idea of their services surrounding the value-based care space. Now, just again, in full transparency, we are having some technical issues today with our hosting company, but that should be resolved within the next 24 hours or so. So definitely come and visit ACO Exhibit Hall and see them there. And then lastly, if you have any questions for either of our speakers today, please don't hesitate to reach out to them. Their contact information is here on the screen, and they'll be happy to answer any questions that you may have, or you can reach out to me as well, and I'm happy to put you in touch with the team. So thank you again so much for your time today. I know there's a lot vying for your attention, and so thank you for choosing this, and hope it was this presentation was informative and helpful, and hope you join us next time. So have a wonderful day, and thank you again.
Thank you.
Thanks, Garrett. Thanks, Dr. Polich.
Thank you very much.
Bye-bye now.